So we are live here with Dr. Brian Barczak. Dr. Brian, I appreciate you taking time out of your busy schedule to join us today, all the way from Kentucky.
No problem, Mr. Coleman. Glad to do it anytime.
So before we really dive right into some of the questions, won't you tell the audience a little bit about you, your degree, and things like that, your schooling?
Sure. After finishing up med school at Indiana University, I went to University of Kentucky and did a adult psychiatry residency for several years, and then did a child and adolescent fellowship on top of that. And for bookending purposes, the icing on the cake, I did a forensics fellowship after that. So it's kind of the answers to some of the questions that I might have for people today may be kind of coming from different angles, either from an adult or child or, medical, legal kind of end of things. So just bear with me. My brain kind of goes in several different directions. But after finishing up residency and fellowship, I've been in practice here in Kentucky for several years, and blessed to be part of the UBHS family for the past several years too. So, I'm just glad to, have hopefully some clinical pearls, and maybe people will get something out of us they can use every day in the day-to-day dealings with folks.
Yeah, and I think one of the purposes of this is to provide instruction and to, in some ways, show what the practitioner thinks about. And it's many layers to it, as I would imagine, and it's not just cut and dry in many cases. There's so many variables to treating a patient, and I think medicine sometimes gets into a viewing people as cookie cutters almost, as opposed to individuals with individual past and history. So,
sure.
So without further ado, I guess it's good. It's almost like I'm talking to three people: the adult side, the child and adolescent side, and the forensic side, the legal side. What do you think makes people and practitioners, psychiatrists coming out kind of shy away from treating children? In your experience, what do you see as the biggest issues, and why you think that is the case?
I found out the hard way coming out of training that, and I was warned about this when I was a resident and a fellow, that children are not little adults, and that, it's not, as you mentioned, cookie cutter. It's not cut and dry as far as like, okay, well, if we're given this therapy or this medication or whatever for an adult patient, we can just scale it back a little bit and, give the child a half dose and they'll be fine.
Mm-hmm.
One of the things that we, as a specialty, psychiatry in general, but especially child and adolescent folks, are finding out more and more all the time that there are so many different variables that go into a patient's response to treatment. It's really hard to predict the end result, 99% of the time. I mean, it's, for example, most medicines that are FDA approved will start around the age of 4 or 5 as far as dose ranges go. But the doses, if you notice, are way, way different, way smaller, way more shrunk down compared to the average adult dose. And a lot of that takes into account the fact that, the child has different metabolism, different height and weight, different body structure, all that stuff. So, you can't say that, if you're treating an adult patient and then you turn around and treat a child the next visit, is it basically just a sliding scale?
Mm-hmm.
It's not that. And the other thing people forget until they're in the room is that when you're treating children and adolescents, there's more than one patient in the room. The parent, guardian, or foster parent, or whoever it is that brings them, always has their own set of symptoms, always has their own set of issues, whether or not they meet the criteria for mental illness.
Right.
They've got their own take on everything, and they've got their own ideas on how the child should be acting and how they should be behaving, whether it's at school, at home, out in public. So, dealing with the adult's description of the child's behavior plus the child's description of their own behavior and then, kind of finding the truth that lies somewhere in between is rather difficult most of the time.
Well, they say it's always typically three sides to a story, and
Sure.
and a lot depends, I guess, on the parents' perception, how they were raised, what they're looking for, what they're cued to be on the lookout for, as to what they'll report. And I'm sure there's several times you've been in with a patient and can clearly see something, whether it be a dynamic with a parent or just a general presentation of a symptom, and you can kind of know what's going on, but you're being told kind of another story. So somehow you have to interject what you see into the parent's reality.
Well, a lot of times that happens, especially in cases where the child or adolescent is talking about some really dangerous or really significant symptoms that the parent is trying to minimize and say, no, they're okay. They're fine. They're not going to hurt themselves or somebody else. And you're
Right.
thinking, in your mind, you don't want this to be the one case that you let the parent make your, clinical judgment for you and say, okay, well, we'll just send them home and hope for the best.
Mm-hmm.
We got to remember that it's our 100th, 200th, 300th patient we've evaluated that, has this, that, or the other symptom, while it's the parent's first child that had that.
Correct. So a lot of it comes down to, having the clinical knowledge, but also being able to communicate that with the parent and having sort of a bedside manner to understand that this is not their 200th child. It's
Right.
number one and their first priority. So,
Sure.
so that leads us into, we've worked with a number of school systems throughout Georgia and Kentucky. And are there any common themes that you see in that same vein of dealing with school-age children? And the children that we see, they come from varying backgrounds, various socioeconomic statuses. Some are DFACs, Department of Family and Children's Services, and come with their own specific issues. Are there any themes that you see? And I guess, what would you tell a school? We've had, with all the shootings and all the, and I think back to when I was growing up, it's a different time and place now. There's new pressures. There's new things that internet, Twitter, Facebook, all these pressures that the kids face. Are there any themes that you see with a lot of these children in schools?
I think, to borrow a phrase from the Department of Homeland Security in our beloved federal government, I think I would say the school, if they took the approach of see something, say something,
Mm-hmm.
would be much better served when it comes to a lot of these kids' cases. And I think one of the things that I've noticed, especially in both Georgia and Kentucky, is an underutilization of the school counselors or the school therapy services and stuff, because while there may be, several hundred students paired up with, one or two or three counselors in the school, they still don't get the number of referrals that we would expect for that patient population. And one of the things that I've seen too in visits for either, checking in on therapy progress or medication management or both for these types of patients, I think that a lot of times the parent will be surprised by what the therapist or the counselor or even the teacher has to say about the student's behavior, because in some cases the patient may be a complete angel at home.
Mm-hmm.
They find out that they're really acting up or really having a tough time in class. And then the flip side of that is true as well. Like an angel at school, and the teacher can't believe that they're raising all kinds of pain at home. So
Right.
I think that trying to have as many parties dialoguing together as possible during the young person's treatment there through the school, especially if they're contacting us and asking us to see on school grounds and having the parent come in, having them conference ahead of time and say, okay, well, this is what we're going to tell the doctor because this is what we're seeing. And let's get it all together. A lot of times, if I see one or the other party in the visit and then the other one comes in and gives their side of the story, it's like there's been no talk at all.
Right. So I guess one question that I'm thinking of is how do you deal with parents who are, are anti-medication, so to speak. They'll give their child, if they got a cold or something, they'll go to the doc, the pediatrician, and they'll put them on, whatever medications required. But when we're talking about psychiatry, there still remains somewhat of a stigma, although to a lesser degree. But there's still some stigma attached with, well, I don't want my child on medication. How do you kind of talk to them about, I guess, medications and things like that?
I tell them honestly that I'm anti-medication as well.
Okay.
And I say up front that, look, whatever we decide to do treatment-wise that you feel is best for your child, let's make sure that it's something that's as temporary as possible.
Mm-hmm.
Okay? So I'm not planning on, if we're going to use therapy or medication or whatever, I'm not planning on using this for the rest of their life, if at all possible.
Right.
I want to try and get them as stable as quickly as possible, let them get what they're going to get out of treatment, and then move on and, enjoy life. So I think telling them that I like to use the least amount of medication possible. For some patients, that means no medicine at all.
Mm-hmm.
You tell a parent that, a guardian who's really anti-medication to start with, you can just see them visibly relax in the session.
Because we all come in with our own preconceived notions, but looking at it like, okay, this is a cast on your leg. You don't leave a cast on indefinitely.
Right.
Once the bone has healed, then you're going to remove the cast. So similar to what you do with it and your approach to psychiatry, depending on the condition, obviously.
Sure. Okay. And I'll tell them too that, I try whenever possible, and this does seem to improve somewhat the relationship between the guardian and the therapist. I tell them, especially if the therapist is in the session, that medication is a good additional treatment or adjunct kind of treatment to the therapy work that they're working on, but that for most mental health diagnoses, talk therapy, this, that, or the other version is typically what usually makes a huge difference for somebody long term.
Correct.
That's the gold standard, and that's, I want them to get the most out of their therapy work. So if the medicine will help them relax or focus or have a better mood or whatever it is for a short term period, so that they can learn skills and take that with them the rest of their life. Mm-hmm. Medicine is not going to work as long as it's in your bloodstream.
And my guess is that in some patient presentations, medication is needed initially to get them to a point where they can actually take in therapy and utilize it, whether it be psychosis, bipolar, if they're in a manic phase. I don't know how much they would retain or be able to participate and gain insight and gain coping skills without a certain level of medication to get them to more of a baseline level.
Even severe cases of anxiety or ADHD, to go along with those examples you mentioned, are ones that parents will kind of complain about, like they just can't sit down long enough for us to get a thought across to them.
Right.
So.
Right. And I can imagine being in a classroom and the overall distraction of even one child who's acting out. It places a great strain on teachers and various faculty alike, just trying to cope with that.
Absolutely.
And then my guess is parents, a lot of times they don't know where to go. They kind of just throw their hands up because they're not sure what they do, or they just toss it into the bucket of, well, it's just a phase. So being able to get them to understand what's going on and that there is help available is a huge step in the right direction.
Sure.
I guess one other issue, you talked about FDA and children under 4 present kind of a different opportunity and a different issue as far as prescribing practices go. What do you see as, the pitfalls there? Obviously, you can use some medication off-label, but that's not always what you want to do. How do you typically go about that? If somebody calls and says, well, I have a 3.5-year-old who's exhibiting these symptoms.
One of the things that I think it's really important for for us practitioners to remember when it comes to this young group of people is it's really hard to tease out at that age range what's normal development and what's budding mental illness. Okay. So while a child may be off the walls and climbing all over furniture and running circles around their parents at the age of 3 or 4, doesn't mean that by 5 they're not going to be calmed down.
Mm-hmm.
I mean, just as the white matter of the brain is developing, as they're becoming more and more mature, not only emotionally but physically, it's going to. All right, timed out there, guys.
Are you back?
Yeah, I'm back now. Can
Okay.
you guys see me? Sorry about that. It said I had like 30 seconds remaining, that logged me out.
Oh, okay.
So the other thing that is really important for us to not jump the gun on is remember that these medicines that we were using for young folks haven't been around forever.
Mm-hmm.
They've been around for the past few decades in some cases. And in other cases, they haven't been around, for even a decade yet. And we don't know in a lot of these circumstances what the medicine is going to do to a person's growth or the person's development or brain maturation or whatever. So because they're so impressionable, they're basically like little sponges, not only, behaviorally speaking, but whatever we put into the system at an early age may have long-term effects, good or bad, down the road, and we're not really sure, unless we have definite symptoms that we need to target for safety purposes or for them to be able to advance in school or whatever. A lot of cases I've had in the past for people under 5 is telling parents, look, you may want to just wait for 6 months or a year or whatever before we think about, putting them on some medicine while we work on this, that, or the other therapy.
Mm-hmm.
And just take the approach of doing that, one step at a time instead of having to rush into it and say, okay, well, we got to pick this medicine for this 4-year-old right now.
Right. And I would imagine some parents come in with views of, well, we got to get them on medication immediately. Whether it be they're acting out significantly at the home or school, they're in danger of being kicked out of school or pre-K. So I imagine that is quite a challenge with dealing with that population and age group.
The other thing that I think is under-recognized and not talked about enough with parents, especially single-parent households, is how much the parents for young folks that are acting out or they have mental health symptoms that are starting up at an early age, how much the parents need reassurance and how much they need a break and how much they need some support, whether it's through like family therapy sessions or like individual therapy for the parent or, just somebody to watch the kids for the weekend, grandparents, family, that kind of thing, just to have a little bit of a breakup in the monotony of dealing with whatever it is they're bringing their child in for. Trying to highlight that and reassuring parents that they're doing the best that they can do is something that, it's worth its weight in gold if it comes from a practitioner saying, I know that you're working hard, you're doing your best. So, we see that. We just have to work around this, that, or the other symptom for your child, and we'll get there. Just be patient,
And sometimes I would assume that sometimes it's powerful to say you're not alone. To realize that there are others who struggle with this as well.
Sure.
And to not feel like you're on an island by yourself, because, a lot of people do not like to talk about these things outside of, a professional setting. So it's a lot to carry around.
Yeah, sometimes referring parents to even like, local support groups and things like that through NAMI or things that they might be able to access where they can feel, like you said, that they're not the only one out there dealing with a child with ADHD or autism or depression or, anxiety or whatever the case may be. They realize that they're not the first family that's ever gone through it.
Right. So that can be a great comfort to a family. And I think a lot of times, mental health professionals, sometimes we take for granted some of the knowledge that we have that's not really disseminated to the public. So we tend to overlook some of the basics.
Sure.
And I think we see that sometimes as well. I don't know if you would agree or not, but
Yeah, absolutely. I mean, a lot of times we underestimate how much comfort can come from just sharing a little bit of what we've learned, not just book wise, but experientially over the years with some of these parents, and just telling them, like you said, supporting them and saying, hey, you're not alone in all this. And, we've seen this, that, or the other number of cases, and this is how many good outcomes we've had. And
right.
Just kind of give them some reassurance that, hey, there is a light at the end of the tunnel is a good idea.
Just got to make it through this little rough patch. But,
right.
Okay.
I usually use the analogy with parents, and they can appreciate this if they've ever taken their child, especially to an amusement park. I usually tell them that mental illness, especially ones that start, early on in life, is kind of like a roller coaster. You're going to have your ups and downs. You're going to have your dips and turns and stuff. But all you got to do is hang on to the end of the ride. Get there. It's just a matter of, how many ups and downs are you going to have along the way.
May not always be comfortable.
Right.
But yeah, absolutely. So, the specific populations obviously cause you to treat it from a different lens. So one population that we work with are individuals in DFACS care, Department of Family and Children Services. And oftentimes these children are coming from, whether it be an abusive background, and they go from foster home to foster home. What are the specific challenges that you see in treating that particular population with so many layers and the trauma component?
Trying to first and foremost get the right level of involvement in the case is really important. I think a lot of times practitioners are tempted to use the savior kind of approach. We've got to do it all for everybody that comes in. And while we do have to do a great job for everybody, that crosses our path, I think we got to remember who we are in the treatment team. Like, we're kind of the hood ornament. By the time a DFACS child comes to us, they've been referred through the state services and the different levels of care that they've had to reach a psychiatrist. We're kind of like, the last cog on the wheel that they've accessed.
Right.
We're not the first contact typically. And a lot of times there's a mountain of history that other people have accumulated that may or may not be shared with the foster parents, or the guardians may not know about it if they're a recently adopted child. Even the state caseworker, the DFACS caseworker, may not be privy to everything that's going on. So one of the things that I usually try and do in the first or second session is make sure that we've contacted the DFACS caseworker and or their supervisor to make sure that they're going to send over a chart for us to take a look at and see exactly what not only the person's psychiatric history is, but their medical history, to figure out, hey, has there been abuse? Has there been, hospitalizations in the past, things that other people wouldn't necessarily know about, when they are changing foster homes every month. Something's going to get lost in translation along the way, typically.
So really you end up being a physician/detective, because you have to you have to put it all together in a coherent manner. Go ahead.
No, I didn't want to cut you off.
Well, I was going to say that I'm sure foster parents come in who have just recently gained custody. So they come in and almost it's a blank slate.
Sure.
The child has 6, 7, 8, 9 years, but it's almost like they were just born with this, in a manner of speaking.
Sure.
They have no knowledge.
That's a good way of putting it, because a lot of times I'll get a referral sheet in front of me for a brand new patient in DFACS custody, where they have this laundry list of medications and laundry list of diagnoses. And all the foster parent can tell me is, well, for the past week since they've been with me, everything's been fine. And I'm just kind of like, well, obviously something wasn't fine in the past because they're on 10 different medicines.
Right,
so
exactly.
I think the other thing that we are not used to doing as providers is deferring to the judgment call of somebody from afar when it comes to DFACS. Like, because typically the DFACS caseworker is not in the session with us.
Mm-hmm.
We're basing medical decisions and treatment changes and medication adjustments on the report of the foster parent or whoever the child is living with, plus the child's symptoms.
Correct.
But then we have to take all that, tally that up and put that into a coherent narrative to kind of share with the DFACS worker and say, look, based upon this, this, and this, I recommend this medication change or this therapy or whatever. And then we have to wait for them to approve it.
Mm-hmm.
So it's not like it's easy for the foster parent to come in and say, hey, I want their nighttime medicine increased. It doesn't work like that because they're not the one that gives consent. So
right, because even if it may be warranted, then it still has to be signed off by state officials. And I'm assuming a lot of that is born out of fear of legal matters.
Right.
I'm sure somewhere along the lines, some entity was involved in a lawsuit, which caused all this documentation that has to occur, to kind of like a trail of evidence, so to speak,
sure.
almost. One of the other things that I think's of note too is, foster care, typically they have their own counties, DFACS counties. But if you go from one county to the next, one thing that I think benefits UBHS as an organization is with telepsychiatry, we can see anybody in any county. Where a physician who is boots on the ground, so to speak, and face-to-face all the time, where they're going to lose that doctor. And the problem becomes continuity of care.
Sure.
So when you've got a child who bounces from 3 or 4 foster homes that are in 3 or 4 different counties, it's not surprising that the medication gets somehow lost. As to what was working before, they may be started on something new, which causes multitude of problems. It's for the child's welfare at that time. Plus, you may have a child who loses faith in the medical establishment as it is. I would imagine that happens quite frequently as well. How do you think we fix this?
It's not something that on our end of things, I think we're going to have the ultimate power to fix. Ultimately, I think at the DFACS level, they've got to recognize the fact that, I'm going to try and put this as politically correctly as I can.
Absolutely.
As different jurisdictions or different counties decide to operate, there's got to be some kind of overarching continuity.
Mm-hmm.
Because if I see a patient from Lowndes County in southern Georgia and they get transferred up to Peachford and they're sent to a foster home in the Atlanta area,
right?
We're trying to contact their former DFACS caseworker or whatever to get records sent over. And they're like, well, you can handle that with Fulton County. That's not how we do it down here in Lowndes County.
Right.
There's a lot of unnecessary, I think, territorialism.
Mm-hmm.
More of like a tribal kind of attitude. It's if you're in your local area of the state, and I think UBHS kind of transcends some of this, like you said, because we can see patients in different locales, all throughout the day, and very, very quickly, very easily. And the people that live there in that population and stuff, they get used to things being a certain way. They have a certain doctor that they've seen.
Mm-hmm.
They close up shop or they move their practice or whatever. They're kind of like,
right,
what do we know? So,
and you've had instances in which either DFACS workers or the new foster parent has called to continue services, which I think is a great step in the right direction. Mm-hmm. So I think there are answers out there. When you're talking about anything governmental, I think you have a lot of red tape and a lot of things that you have to deal with that we're not always privy to on the outside.
Sure.
But
As anybody that's familiar with certain professional sports organizations and leagues might know the phrase "do your job."
Mm-hmm.
That's kind of a popular thing that's circulated on T-shirts and things like that. I think we just need to know the limits of our role and say, okay, well, we'll do what we can, the best that we can for every patient who walks through the door.
Right.
We'll operate within the system as it is for the moment, but just realizing what the limitations of our power is. I mean, our power is to assess and treat as best we see fit, and not let other people kind of hijack our clinical judgment.
Right.
Above and beyond that, when it comes to the governmental stuff.
Well, and insurance as well, because I think one of the things that you can attest to, I'm sure, is you have a medication that you feel would be a great fit for this patient, but it's more a newer generation medication. Whereas the insurance would prefer that the patient be tried on several older generation medications and have trial failures a number of times prior to being granted this medication.
Sure.
I guess how frustrating is that for you, and how difficult is it to explain to a parent that we have to get prior authorization prior to putting your child on this medication?
I think parents can kind of sense the frustration of the practitioner. At least I've had several conversations like this with parents over the years where they say, okay, so my kid is just a guinea pig, to have, a bunch of different failed medicine trials until we can play their game and reach the number of failures until they will actually approve the one that we want.
Right.
I think one of the things that we can do to streamline that process, the best that we know how, is to document anything and everything you think is going to be significant when it comes to symptoms or side effects or treatment response or things like that, because that will clear out some of that red tape in some cases for patients. And I think, it's frustrating because people that didn't go to any kind of medical training program end up making the decisions about what's best for your patients when they,
especially at the front line,
right? They've not even met them personally. So
right.
They're looking at the name on a paper and saying, well, they haven't had 3 trials of a non-stimulant before, we're going to give them a stimulant, So,
right.
It's trying to be humble and say, okay, well, I do know what's best, medically speaking or psychiatrically speaking, but I'm going to play the game and
right.
And jump through the hoops for. But, one of the things that people forget about is a failed medication trial doesn't have to be a certain length of time.
That's true.
So you can.
They can have any side effect, whether it be GI distress, anything like that, and that's important for parents to know as well.
You can try something for a week. It doesn't have to be a month.
Correct. Right. Absolutely. So, but the problem that gets into is you're putting this child through a lot of issues, and they may decompensate and have to be hospitalized, which is a tremendously traumatic event for a child and parent.
Sure.
To have to go through that. So
yeah, I think when I tell parents about medications and stuff, I try and, when we're starting somebody on a new trial of treatment, whether it's new prescription or new therapy or whatever the case may be, tell them that, look, we're going to meet up in like 2 or 3 weeks instead of waiting a whole month or more. Because if we're having side effects or we're noticing that something's gone haywire, we want to catch that early and not wait. And if they're thinking that hospitalization's on the horizon, we definitely want to catch up with them sooner rather than later to make sure that we're on the front lines with them and making that decision too.
Okay. One thing that parents, I don't know that they truly understand is the stimulant family of medications, the Concertas. I guess some of the dangers, and I think you're very good, and I've seen other prescribers do as well, but some parents may come to you and they want relief immediately. which it makes sense. We all live in an instant gratification world. You know, we want everything's a drive-through now. Everything's quick, everything's convenient. But tell me how to tell and how do you talk to parents about we need to get baseline labs? Why are they important? EKG, why are these things important prior to introducing the treatment?
Telling them about the risks that are actually documented in the medical literature about, especially kids with a cardiac history, anybody who's had any kind of even borderline development, not necessarily abnormal heart development, but borderline development. Like a lot of times kids will have some other kind of birth defect that will signal that maybe there's something wrong with other internal organs. Like, for example, if a person was born with like a abdominal hernia and some of the intestines were actually outside the abdomen or something like that, or they had like a problem with their spine or something like a cleft lip or, cleft palate or something like that. Usually that means that something along the way in development didn't move where it was supposed to.
So would that give you an indication that there's probably other things? There
may be other things. And that's kind of a clue. And I'll tell parents that, look, if this could happen here, in the mouth, could that have happened somewhere lower, like in the chest or the abdomen or something like that? So, and a lot of times if somebody has a problem with their heart or they've had any kind of cardiac symptoms early on in life, there's usually a family member or two that has had something similar along the way. So asking parents about a family history of anybody who's had a murmur, heartbeat trouble, dizziness, or passing out is a good starting question. Same is true for the child themselves, because if the answer to any of those is yes, getting a baseline EKG is absolutely what's recommended by the American Academy of Pediatrics and the American Cardiology Association, all that stuff, because they know that putting somebody on a stimulant or putting some medicine in the system that's going to speed up the heart or make the heart work harder, if there's already a defect in there, you don't want to give a 7-year-old a heart attack.
Right.
I'll explain that to parents and say, look, your child is too healthy and too important.
Precious.
Precious to stress them out with a medicine that may or may not be good for them.
Right.
As far as symptom wise, may not work the way we want it to. And secondly, we don't want to give them more harm than good.
Right.
So, that's where the EKG issue comes in. And if there's ever a family history of anybody who's died suddenly or unexpectedly at an early because of their heart in the family, even if it's a distant relative, that's an automatic screening.
Right.
In my book. Now lab, it's less important for labs when it comes to stimulants, unless there's a history of somebody with growth restriction or not thriving adequately. So somebody who has had hormonal issues, they're not at the height or weight we'd expect them to be for their age. They're kind of on the small side, or they're not like a teenager that's not developed any kind of like adolescent or teenage characteristics. They don't have any, body hair where they should be, and things like that. You wonder what else is going on internally that's not working the way we expect it to. So getting things like some basic metabolic studies and things like that becomes that much more important for kids that we know are already behind the 8 ball.
Right. So when a child comes in, it's you're looking at pretty much all of the systems, and it's almost like almost akin it to, I know this is a RoboCop. Now, RoboCop has a scanner that goes down and kind of picks up various things. So you're almost doing that from a practitioner standpoint to see what you pick up on. Whether it be fetal alcohol syndrome type presentations with the face. So you're automatically scanning, and it's pretty interesting to see.
I always try to tell parents, and I think that this is something that I found was, appreciated by some of my medical colleagues when I was in training, that psych was often looked at, especially in the hospital, as being like the dumping ground for anything that anybody else didn't understand. But I tried to explain, to my colleagues back in the day, and I do so with parents now, that we don't want to assume that anything is mental health in nature until we can prove that there's nothing medical going on.
Mm-hmm.
So I think getting some basic screening out of the way early on in treatment, getting some lab work, getting some tests on the heart or whatever the case may be that's appropriate for the medicine that we're thinking about prescribing, it gives not only the practitioner some peace of mind that we're doing the right thing, we're doing this by the book, but also it shows the parents that we're being thorough.
Right.
And it shows them that, hey, we're thinking of all possibilities. We're not just looking at this from, okay, well, somebody is anxious and they're up out of their chair and they're not able to stay in class because they're having panic attacks. Well, is there something going on like with their hormones? Is there something going on with their heart? Are they not able to sit down because they can't breathe well?
Right.
Like that. I mean, I think scanning from head to toe and saying, what could this be? Excluding the brain, excluding anything psychiatric. What else could this be? And putting that into, a few sort of succinct, tests that kind of can lead you down other paths, like, getting something to test the kidneys or getting something to test or whatever, the thyroid, things like that we know can go out pretty easily. It can make a world of difference because, sometimes if we don't treat the medical issue first, we can throw the kitchen sink at them psychiatrically. And it's not going to make a bit of difference until you get the medical stuff fixed.
And I think there's more knowledge than it used to be about, the mind lives in the body.
Mm-hmm.
So there's going to be a mind-body connection. And a lot of times something that you perceive in the mind, you're going to have physiological impact, whether it be raised blood pressure, a number of things. And it may not originate within, I guess, the organic system. It may be psychosomatic type illnesses and things like that. So I think it's important for practitioners to look at that whole holistic type system.
Well, and I think too that a lot of people, like you're saying, forget that the human being is more than the sum of its parts.
True.
The mind in and of itself is not all who we are, just like the body is not all who we are. But if you put it together, we're something more than even all that.
Right.
So I think if we try and break it down and compartmentalize it too much and say, okay, well, this is a brain problem or this is a thyroid problem, this is whatever, you're forgetting about all the other effects on everything else.
Yeah. And there's still a lot we do not know. The mind is an amazing machine that
we haven't even scratched the surface yet.
Right. Absolutely. Okay. So before we, I guess we're running out of time. It seemed to flow by pretty quickly. I do have a question that actually comes from one of our nurse practitioners, and it involves non-suicidal self-injury in adolescents. And it looks like it concerns, are there any suggested PRN medications for co-occurring disorders, such as mood disorders, anxiety disorders, eating disorders, things like that, that kind of help in the treatment of ending the self-injuries, the cutting, things like that, which is a very difficult patient?
Sure, absolutely. Well, traditionally, in adult populations anyway, lithium was always considered the only medicine out there that actually protects against suicide. We're finding out more and more over the years that that's not necessarily the case. According to, the side effects that it causes and that kind of thing, it's not a good first-line medicine for adolescents because it'll cause things that they can't stand. Weight loss, hair loss, tremors, acne breakouts, skin, things like that, stuff that's going to matter a lot to a young person and their self-image and stuff. So,
absolutely.
This is going to log out here. I'm going to log right back in and finish the thought, okay?
Okay.
There we go. Sorry about that, guys.
There we go. Back to live action.
This timer has a mind of its own. So according, and I looked this up, I'm glad that this question came in because I looked this up. According to the NIH, currently, the medicines that they recommend most strongly for adolescents who have a history of non-suicidal type injurious behavior are first and foremost like antipsychotics like Abilify specifically is considered to be top line because of the mood component that it carries as well.
Mm-hmm.
SSRIs, specifically ones that we know are safer to give in people under 18, Zoloft, Prozac, and Lexapro are at the top of the list. And then off-label medicines like naltrexone, if you can get the guardian to consent to a medicine like naltrexone, it can actually decrease the cravings for injurious behavior and the reward that comes from those. Okay, so those are things to consider. And then for the comorbidities, the things that go hand in hand with in the background, separate from the self-injurious stuff like the eating disorders, the mood, the anxiety stuff. Scheduled medicines, in my experience, are much better than PRN meds.
Mm-hmm.
The only PRN med that works well for adolescents that I've seen anybody under 18 is actually hydroxyzine.
Okay.
Never, ever, ever use benzos for people under 18 because of the behavioral discontrol and the crazy things that they can do to the developing mind. I mean, people get in their cars in the middle of the night and they start driving down the street without even knowing it, things like that. In addition to rages and seizure-like acting out episodes that the person can't even remember, stuff like that. Not a good idea for people under 18. The other non-traditional antidepressants or anti-anxiety medicines like Cymbalta, Remeron, Wellbutrin, those are all FDA approved for people under 18 as well. So, if some of the more traditional SSRIs don't work, go outside the box and try and use something that maybe they've never been on before that are typically reserved for adults, but nowadays they've been approved for younger people too.
Right. And I think in aligning everything else that you've said, obviously therapy is a have to have in these type situations because there's typically some underlying trauma. Typically.
Sure. I usually warn parents against having a person be put on medicine unless they're already involved in therapy.
Right.
Just because medicine itself works maybe 50% of the time on a good day with the wind blowing, all sales going. But therapy in and of itself, by itself, works more than 50% of the time. You put those two things together, you're going to get an 80-90% response rate for most mental health conditions for a young person just right off the bat.
Right.
So much better outcome typically once they're already involved in therapy, and then you add medicine into the picture.
Right. Sure. Well, I feel like I could keep talking. We could probably do about 15 more of these on various topics, including benzos. And it seems like I think the benzo epidemic continues to grow. I just don't think it gets the notoriety that the opiate addictions epidemic do, but I think it would be worthy of a conversation at some point in time if we could ever get you back. I know you're a busy man, but I want to thank you for joining us today and look forward to many more conversations, and thank you for everything you do. We certainly appreciate everything that and who you are. So we appreciate you.
I'm glad to be part of the family,
Absolutely. Well, thanks again, and we'll talk to you soon.
Thanks, sir.